unwind from the traffic in Kuala Lumpur.
Feast your ears to soothing music on your favorite station.
TRAXX FM 90.3 Kuala Lumpur.
It's a 11:15 right here on TRAXX FM. Time to bring on the segment over here. It's the health segment with Norlida as producer in the studios of TRAXX FM. Our guest on the phone or via phone this morning is Dr. Ibrahim, as it like to be known, but he is Dato' Dr. Muhammad Ibrahim bin Dato' Haji Abdul Wahid, consultant clinical oncologist. Our topic this morning is the future of cancer care. Good morning, Dr. Ibrahim.
Good morning. How are you?
I'm doing fantastic. Thank you.
Great.
And I hope you're doing all right as well.
Very good. Thank you.
Year end,
Thank
and
you for inviting me for the show.
thank you for obliging and being here with us as well. And Dato', what's your new year going to be like? What's your resolution like?
I hope we can be better than last year.
Isn't that?
I mean, we missed all the traveling and because we do a lot of charity clinics and all that, and we are unable to do that. So hopefully we can resume normality. So my hope for the new year is to resume normality for 2021.
And normality for you would be going around and doing charity clinics and stuff.
Clinics and traveling, attending meetings,
Right.
those sort of things. Yeah.
Well, pardon my ignorance, but what's a charity clinic? I mean, I can imagine it's.
We do. I used to go to Sabah, and we do charity clinics for patients who are less privileged, and they want opinions on cancer treatment and about what sort of treatment they should be going through and things like that. So we normally give advice on treatment, and so that patient put them on the right track,
Right.
in terms of so sometimes they need explanation and they need more clarification information about treatment. So that's what we do to help them and point them in the right direction and help them, advise them on appropriate treatment for their cancer.
Right, fair enough. A lot of times we're afraid to ask doctors questions, and then when they give us an answer and it's not clear to us, we'll just nod our head in agreement and just say, yeah, like we know what is going on, but you're the doctor and we're not, and yet we still are afraid to ask. Should people have that attitude? No, you should ask, right?
No, they should ask. I always encourage my patients to ask questions. Because at the end of the clinic, I normally ask them, do you understand? Because, yes, you're right, because sometimes doctors, we are so technical, and we explain things in such technical jargon, and at the end of the day, patients, don't understand what you're saying, and they are afraid to ask, or too shy to ask.
Mm-hmm.
Or sometimes when they ask questions, the doctors also get a bit irritated. So which is actually not quite right. So we should be patient and advising them on, because certain things where we take for granted, patients don't know certain terminology that we use. Patients don't know. So we need to clarify and make sure they understand. And we just have to take our time explaining, because sometimes when patients, especially patients with cancer, when they come and talk to you, their mind goes blank.
Mm-hmm.
They don't know what to ask. They don't know what to say. So I always encourage them to bring a relative along, so that will help to reinforce or help them to remind them on what was discussed during the consultation, so that they don't get lost and there's always there somebody to support them. And I always tell them, okay, you go home, you come back, and then we'll discuss things again about treatment. Once you are absolutely clear about what are the treatment that you need to go through, only then we will initiate treatment. But the key thing here is not to tell the patients what treatment you're going to give, but to make them understand why you are giving a certain treatment.
Correct.
Then you will get better compliance when you actually explain to the patients why they need to go for certain treatment, and it's not like dictating treatment to them and say, hey, you must have this, and no questions asked, because I'm the doctor, I tell you so.
Right.
That's not right. I think the key thing here is to actually make them understand. And a lot of time, when they understand, the compliance will improve, and and they also will help them to understand to go through the treatment process better.
Fair enough. They're not saying N-O, no. They just don't K-N-O-W, no. Right, doctor?
Yeah, yep.
Fantastic. We need a lot more. Is this some kind of a conversation that you have with other doctors around, or is it something that's brought up in the medical association where, communication and how to communicate with the patients is something that has to be improved on? Is that something that's in the pipeline now? Are they talking more about it?
Well, unfortunately, this is something that we need to teach them right from medical school days, and communication sometimes it's not in all the medical school curriculum, and I think it's very, very important how we talk to patients, and different doctors, different things. We talk to patients differently. So I think there ought to be a curriculum on this, but not, like I say, not all medical schools will emphasize on this, but something that sometimes you pick up along the way, and it's just like any other thing. Some people are good at communicating, some people don't communicate well, but I think it's an essential skill for all doctors that we are dealing with patients, talking to patients all the time, so we have to communicate well, communicate in a way that they understand, not talking and hiding behind medical jargons, and then they don't understand, and that doesn't help anybody.
Correct. There you go. You get a fever or something, and they tell you it's viral, and then we're like, okay, viral meaning, and it's like they expect you to know it. So when you don't know it, it's like it's in the air. They'll give you an answer like it's in the air, and then you're just okay, and you're still wondering at the back of your mind, But okay, with COVID-19 at the forefront, and seemingly the biggest health problem we have, and how cancer actually took a back seat, how were you feeling about that?
Okay, I think with COVID-19, it has caused a lot of disruption in our normal flow. Patients, we are restricting patients. Patients are sometimes restricted from traveling and attending their regular clinics, and they are also restricted from, visiting, hospitals and things like that. So there are a lot of issues, and the initial part of the COVID, we saw a huge drop in the patients coming to clinic. And then because sometimes there were also issues initially that they had to get police permit, and patients from Johor Bahru coming to Selangor, there are restrictions, so there are a lot of things, but now I think things are going back to normality. Patients understand that their health is also more important, and but what we don't see now are the patients coming from abroad. Our health tourism is still being severely affected, especially patients coming from Indonesia. We hardly see them anymore. But the local patients, yes, they are coming back. They are picking up, and we hope that this COVID issue will, with all these vaccines coming in, hopefully it will start to control and like I say, get back to some form of normality.
That's right.
2021 now.
Correct. And a lot of people, are mistaken if they think that COVID, the vaccine is something that's going to completely eradicate the problem. We still have to maintain a lot of other things like the new norms and the SOPs, right, Doc?
That's true. It will take for the a bit of time for the vaccine to kick in. Even if we have a vaccine now here today, it doesn't work immediately. It will take several months before we see the results of sort of herd immunity. Yeah. So so it takes time for a lot of people to build up the defenses and stop this infection from spreading rapidly.
Right.
It will still take time, yeah.
In Malaysia, when we talk about herd immunity, how many percent of the country do we need to see vaccinated?
We have to try and get as many patients as possible, people as possible, at least well above 80%,
right.
That kind of figure at least to get a good immunity. But still people have to be vigilant. While the vaccine is still not available, we still need our social distancing, wearing masks, and wash our hands, and have good habits, and be careful not to wander around in public places unnecessarily.
That's right.
We still have to, do the normal sort of, precaution.
Correct.
Preventive measures, yeah.
Correct. And the future of cancer care. Now, we're talking about personalized healthcare, and what does that mean to cancer patients?
Okay. Personalized healthcare is something that we are now looking into, in terms of cancer treatment. Now, here we are talking mainly about stage 4 disease, where the cancer is very advanced. Previously, what we do is giving patients chemotherapy and then more chemotherapy. But things have evolved, so we are now moving towards targeted therapy. And what does targeted therapy mean? Targeted therapy means we target certain pathway in the cancer sort of development process. So there is a certain genes that can be triggered that makes the cancer cells grow. So we try to identify the pathway, the defective pathway that actually promotes the cancer growth, and we try to block that pathway. So now personalized cancer care is now moving towards identifying some of these pathways that actually make these cancer cells grow, and we try to actually block the growth process. So there's using certain drugs that we know will be effective in halting the growth. Yeah.
Right. And with the current technology that allows more information to be collected, how would this translate into useful insights that can benefit the clinical practice?
Well, I think now with all these technology, how it benefits is we can customize or tailor-make treatment better. Okay, so let me give you an example. Now, say for example, lung cancer. We have been treating for many, many years, treating lung cancer with chemotherapy. It's a sort of it's a blanket carpet bombing sort of technology where we just, inject the drugs into the patients, and then it just destroys not only the bad cells, but also there are a lot of innocent bystanders. The good cells also get damaged. Then what happens is somewhere about 10 years ago, more than 10 years ago, 15 years ago, they found a certain gene that actually makes these cancer cells grow, and they call it the EGFR, epidermal growth factor receptor. And they identify these receptors, and when they find that there is a mutation or there is a change in these receptors, these cells begins to grow uncontrollably. And there were drugs that were used that could block these receptors, yeah? And by blocking these receptors, we could actually control the cancer growth. Now, blocking these receptors is nothing new. You see, like, say, for example, like in breast cancer, we have a hormone receptor, the estrogen receptor and progesterone receptor, and we use tamoxifen or anastrozole or letrozole to block these receptors, these drugs, anti-hormone receptors to block these receptors. But that was mainly in breast cancer. In lung cancer, this was a game changer when we found out that there are receptors. So since then, doctors and scientists have been trying to look for pathways where they can identify all these aberrant or receptors that have gone wrong or mutated, and look for drugs by profiling the genetic material, as it were, in the cancer cells, in the tumor cells, and to identify where these aberrant defects are, and customizing the drugs to actually block that particular pathway, and hence controlling that. So so we are more targeted towards our treatment rather than carpet bombing. So we just go for sort of zooming into the target.
Right. And comprehensive genomic profiling, is that where we're getting at? Yeah. What is comprehensive genomic profiling? Is it different from the usual biomarker testing we see on a regular basis?
Right. So now, in clinics, when you sit down and talk to doctors, when you have lung cancer or colon cancer or breast cancer or whatever, we talk about, we need to do biomarker testing. So biomarker testing, last time when you do your pathology results, what you do is when you just tell you, you got cancer, you got lung cancer, you got adenocarcinoma, you got squamous cell carcinoma. We tell you the type of cancer. So now we go one step further from there, and we do something called what we call biomarkers. Biomarkers, like we say, are some of these receptors or mutations that we find. So by doing biomarkers, we are just looking at a few biomarkers. Maybe like for lung, we look for EGFR, ALK4, ROS1. These are the names of the biomarkers that we look for. Like colon cancer, we look for KRAS, we look for NRAS. So we look for specific biomarkers for specific cancers, and then we find that we can then target. But when we do a comprehensive gene profiling, we are actually testing for over 300 genes. Yeah. So we are not just looking at a particular specific biomarker. We are doing a comprehensive profile of the gene to see where are the potential mutation in that gene. So it's more sort of broad-based testing. It's more wide-based testing, so that we can try and identify more sort of defective genes that and open up more doors, as it were, for us to find suitable drugs for that particular patient.
Right. And you seem, I can hear it in your voice. You're very excited about the advancements of cancer treatment, just as we would be excited about a release of a new song. And yes, how excited are you, Doc?
I think, like I said, this is a game changer. I've started using profiling, comprehensive genomic profiling, for several years now, because I found that in some very challenging cases, we managed to help a lot of our patients. So it has certainly changed the way I manage some of my patients, and sometimes I manage to find solutions for the most difficult patients, cancers that the patients have, to help to control the cancer. So, to me, this is game changing. This is something that's very, very helpful in my clinical practice.
Right, and we're very glad that's happening. Yeah, and having a diagnostic tool like CGP, what is the immediate impact on the management of a cancer patient?
Okay, I think the impact is there. Let me just answer this by telling you a story of a patient.
Please.
Okay, so this particular patient had lung cancer, and he had all the usual so-called common biomarker testing, and unfortunately it all came back as negative, and the patient underwent chemotherapy, it didn't work, went through another chemotherapy, it didn't work, went through immunotherapy, it didn't work, went through another targeted therapy, it didn't work. And by the time he saw me, he was already 6, 7, 8, 9 months down the line, and he was gasping. He came to my clinic on a wheelchair with oxygen, and he could hardly talk. And and we saw that he was very, very weak. So I told him, I said, there's no point having any more chemo, there's no point having any more immunotherapy, because it's not going to work. So the only way I can help you is, let me take a biopsy, because he had a swollen neck node. Let me take a piece of your tissue from your neck node and send it for comprehensive genomic testing, profiling, and he agreed. So it takes about 2 weeks for the test to come back. So he waited, and lo and behold, I told him, I said, hey, sir, I got good news for you. I found a target that I can block. And this patient was on a wheelchair, and his life expectancy was like weeks. I managed to find a drug that, that hit the nail on the head, and he's alive today, 3 years plus, and he's still alive and well. and with, he can walk into the clinic. He doesn't need oxygen anymore. And, so if you find the right target and get the right drugs for that particular patient, you can change the whole, outcome. And you can help to prolong survival. We can't cure the patient, but at least help to improve his quality of life, improve survival, patients are able to spend a bit more time with their family.
Mm-hmm. That's important.
That's very important. Yeah.
That's correct. And many times, I mean, I'm sure it saddens you when you find out that people resort to going for some other means of treatment, and they end up, dying when they don't have to.
Yes, correct. Because sometimes, partly sometimes I have to admit we doctors are also to blame, because we tell them, look, there's nothing new for you, we got no hope left. And so, when you say something like that, and, sometimes there is no, but then patients starts to seek for, alternative treatment, and they could end up with, in the sort of, in the hands of quacks who promise them all sorts of, cure and at a very high cost. So, sometimes they fall into this because out of desperation,
Right.
they fall into this, and it's very, very sad, because they have to spend a lot of money paying for all these treatment that actually don't work. Sometimes, even with comprehensive profiling, we are able to tell the patients, look, I do not have any drugs here for you, and we just have to sometimes explain to them about their realistic situation. So, some patients can handle that, but some patients just cannot accept that there's nothing left for them.
Right.
So it can be quite challenging, can be quite difficult at times. Yeah.
And the promises you find online from so many people with all kinds of things, and they make it look so realistic.
Yes, correct.
It's so wicked to give people hope when you know that you're not really giving them any kind of treatment at all, right?
True. That's very true. Sometimes when I tell my patients, when it's cancer, it's like you're lost in the sea, surrounded by sharks. They're just waiting to pounce on you. So that it's a little bit like that.
Right. So, okay, as we know, now this one over here, tissue biopsies have always been the gold standard for genomic testing. However, there are instances that tissue biopsies might not be the best option. Would you share with us more on this?
Okay. Sometimes, tissue biopsy, like I say, is the best, if we can take it. But sometimes it may not be accessible. The cancer can be so deep that your needle, cannot reach, or it's too dangerous because there are a lot of blood vessels around, or sometimes the tissue, may not be sufficient, and so what we do is we can take blood and look for what we call the circulating tumor cells. We're looking for circulating tumor cells. These are the free cancer cells that are circulating in the blood, and we see if we can identify and then do the testing on these so-called circulating tumor cells. So tissue gives the best results, but sometimes now we are looking into blood technology as well. Yeah. So with some companies like for example, like the foundation One Medicine, they are testing about 324 genes in the tissue, but they can also test that number of genes in the blood, when there's sufficient tumor cells circulating. So those are the patients when they have reasonably high tumor burden, and it's found in the blood.
Right. And what about liquid biopsy? With the availability of liquid biopsy, how would it transform the current clinical practice? Will that replace tissue biopsy eventually?
I hope it will, because that will make things easier. So as technology improves, it will, and technology is improving. So last time we used only tissue. Now we are using liquid. But in order to move forward with liquid biopsy, we have to do validation. That means what you need to do is you need to compare the results you get from tissue with the results you get from liquid or from the biopsy, and then you see that if both the results are comparable, then only then you can move forward. You can say, hey, we can do either liquid or tissue because the results are very, very comparable. Yeah, but for this, at this moment of time, we still need some tissue biopsy because some of the tests are still not available using the liquid biopsy.
Right. And when do doctors sit back and say, oh boy, what a waste, when it comes to patients and patients not wanting to heed their advice? What makes you say, what a waste?
You see, that's how communication is very important, how we talk to patients, how we explain to them. And, but sometimes despite all the explanation, patients will just say no, and that's it. There's nothing you can do. But, the whole process is trying to educate them and try to explain in simple terms, what they need to do and what are the options left for them. And at the end of the day, patients are patients. They have to make their own decisions. And sometimes you help them to make decisions, but sometimes no matter how much advice you give, they will make their own decisions. So you just have to respect that.
Right. What a waste is what I said, Doctor, when a friend actually had some cancer before, went for treatment and was okay, getting better and stuff like that. And then he starts to see this relative he's not seen in a long time who comes and says, I had cancer before and I got cured by taking this and taking that and all that stuff. And then all of a sudden he stops going for his treatment, ends up,
yes,
going for the other form of treatment, and then and it all turns bad. And we visit him. We say out loud. We visit him and we give him our last respects. He's going to be buried after that.
That's always a shame when sometimes patients get misguided through because one of the key issues is there are several issues why that happens. Number one is because maybe they can't tolerate the side effects of the drugs, and they find that the effects of the drugs are too strong, and then somebody offers a less sort of more tolerable treatment that costs maybe even more, but we don't know, so then they start to sort of change into other things. So that's one. And sometimes but the sad and the more realistic part is actually cost. Sometimes some of these drugs, when the cost starts to mount up, and it's sad because the patients say, oh, doc, I can no longer pay for this, so then that makes things very difficult, because I have seen patients who are responding very well, who are doing very well, but then they can't continue with the treatment because some of the costs of these drugs are very, very, very expensive. So and they may not be funded through our health service, and we can't get them, because these drugs are too expensive, and you can't get it on the government list. So that can be challenging. But sometimes drug companies do have programs that can help them, but still, financial challenge is something that is very, very difficult for us, and there's not much we can do as doctors.
Right. Yeah. And it affects a lot of people, yeah?
And it affects a lot of people.
Right. And your parting thoughts and advice to cancer patients or for the public? Okay.
Well, cancer is, it's not a death sentence. It's potentially curable, especially in early stage. So, if you have any symptoms, or if you're, you go for, like breast cancer and all that, you can go for screening, checking, and early detection and early and correct treatment can cure cancers. It can cure over 80-90% of cancers. It's only when the late stage cancers that we find it challenging. So early treatment, early detection can cure cancer. It's not necessarily a death sentence. We've got new technology, new medications, new drugs, and that can help patients even in advanced stages of disease. So, do get your advice from your oncologist, seek an opinion from your oncologist, because there are always new things coming along, and it's, and it's not like it's a hopeless situation.
Right. Dr. Muhammad Ibrahim, thank you so much for your detailed explanation, your patient explanation. We hope a lot more doctors would have that kind of, patience to talk to patients. when they do. And especially thank you. You've given us half an hour of your precious time. We appreciate that.
My pleasure. Thank you very much, and have a good new year.
Thank you. And to you too, a wonderful 2021.
Thank you. Thank you. Bye.
Have fun in Danga Bay, the largest recreational park in Johor Bahru City.
Trax FM 102.9.
Our guest via phone earlier was Datuk Dr. Muhammad Ibrahim bin Datuk Haji Abdul Wahid, a consultant clinical oncologist, talking to us this morning about the future of cancer care. And Norlida says, thumbs up to me, Norlida? Yeah.